those cases at the end. So the first case is a 56-year-old female with history of pelvic surgery in outside institution. We don't know the exact reason for the surgery. It was for a tumor resection. We don't know what that was. And then she presented years later with abdominal pain. And I hope this plays out well. I skipped the CT. This CT showed some hypodense lesion, and then this is the MRI, axial T2 fat SAT sequence. You can see that there are these scattered T2 hyperintense, kind of similar to fluid intensity lesions throughout the liver. I played the T2 once again. Have a look at them and then have basically an idea of what they look on the T2. And then this is post-contrast. On the left side of the screen, this is T2 fat SAT. And then on the post-contrast, the first one is the arterial, the venous, and delayed images. You can see that one of the dominant lesions in the caudate has this peripheral like continuous, not discontinuous, peripheral continuous nodular enhancement with progressive central filling. And again, it has this fluid intensity on T2. So just have a quick look at these images and have differentials in your mind that what do you think this 56-year-old female with a remote history of a tumor resection, what the possible differentials could be. And these are your choices: hemangioma, hepatic adenoma, focal nodular hyperplasia, FNH, or do you think these lesions are suspicious and you recommend biopsy? I will go through each of these differentials, and then at the end we can decide which one we prefer for this case. So we start with hemangiomas. Of course, they're the most common benign liver lesion. They're not really a tumor. They are endothelialized vascular channels or malformations, if you will. They happen in 7 to 20% of people. They're more common in females. They basically have slow internal circulation with loose fibroblastic stroma. There are basically no real complication associated with them. They occasionally can grow, they can regress with sclerosis, and actually sclerosing hemangiomas can have some specific views on MRI and sometimes can fool us for more important lesions. But a prior imaging that shows a presence of hemangioma in that area is very helpful. They very rarely can bleed. The large ones sometimes are associated with this syndrome that can cause thrombocytopenia, Kasabach-Merritt syndrome, and sometimes they can cause high output cardiac failure in the cases of very large ones, or hemangiomatosis when there is more than 10 large ones throughout the liver. And the diagnosis of hemangiomas are by imaging, and biopsy is not required and also not recommended because there are vascular lesions. So this is the classic appearance of hemangiomas. They are T2 hyperintense fluid intensity. They have this peripheral nodular discontinuous enhancement with progressive filling. Again, I want to emphasize that they have to be discontinuous and they have to be progressive filling with kind of filling the whole lesion at the end, and all of these elements need to be present, and each of them, when they are absent, you need to double check and you need to double think your diagnosis, because it's very easy to miss important lesions for hemangiomas, but they have to have all this peripheral discontinuous nodular with gradual filling of almost entire lesion. Next differential is focal nodular hyperplasia. After hemangiomas, they're considered the second most common benign liver tumor. They also happen in young females, mostly in the 3rd to 4th decade. They are hyperplastic response of the liver parenchyma to some underlying local vascular abnormality. Up to 90% of them are just incidentally found, and they're usually asymptomatic, and 80% of them are solitary. There are essentially no complications associated with them. For young females that are on OCP, sometimes if they continue OCP, the FNHs might grow. And imaging findings are highly suggestive of them. But like, especially nowadays, we are more and more seeing cases that look very much like FNH, but they prove to be other lesions. So we are a little bit less confident of completely diagnosing them by imaging. But if there is anything off with their imaging appearance, of course, biopsy or follow-up can be reassuring. This is a classic look of an FNH. On the T2, it should be technically iso-intense to the background liver. It's actually a differential basically point that when we compare FNH with adenomas, which I describe in later slices, FNH is mostly iso-intense to the background liver, but adenomas are a little bit hyperintense. So when you are trying to decide in between, just remember that FNHs are mostly, basically you lose them in the background liver. They're completely iso-intense. Sometimes they have this T2 bright central scar. On the arterial phase, they have this brisk arterial enhancement. On the late phase, they are ISO2 hyperintense to background liver. And a hallmark of them is the hepatobiliary phase when you use hepatobiliary contrast like Eovist, like Multihance. They basically have similar to increased background, increased retention of contrast compared to background liver, usually with this rim of hyperintensity on the hepatobiliary phase. Although their presentation on hepatobiliary phase is very heterogeneous, sometimes they're ISO, sometimes they have this peripheral rim, sometimes it's just very heterogeneous, but it's a classic look for them to have this rim of retention of contrast. Just a quick note about the hepatobiliary contrast agents and what are we standing right now and what we thought about them in the past. Of course, there are some flavors like Eovist, Primovist, or Multihance. In our institution, we usually use Eovist. This hepatobiliary contrast agents are taken up by the normal hepatocytes via the OATP1B3 receptors. And then usually, again, usually the focal liver lesions that are different from the normal background parenchyma are technically not supposed to take that contrast agent and supposed to present as an hypointense lesion on hepatobiliary phase. However, there are specific lesions that either have that normal hepatocytes or they have increased basically expression of this OATP receptors, and that's why they actually on the hepatobiliary phase they either are similar to background liver or even increased intensity to background liver, among of which the most important one is FNH. The FNH is a basically lesion that has overexpression of OATP, and it has increased well-differentiated bile ducts, and that's why it's characteristically hyperintense on hepatobiliary. And in the past, we thought that, okay, great, so we can diagnose all the FNHs with hepatobiliary. Anything that retains that, it's an FNH, and everything that doesn't retain that is not an FNH. But then later on, we came with this understanding that that's actually not true. A subset of hepatocellular adenomas also, unfortunately, has the overexpression of OATP. And again, even more unfortunately, the versions that do have the overexpression are the ones that have the highest risk of malignancy. The beta-catenin mutated, which has the highest risk of malignancy, up to 83% of them will retain contrast. Inflammatory adenomas, which also carry a small risk of malignant transformation, also 19% of them can retain contrast. The other version of adenoma, which is usually homogeneously fat-containing lesion, the HNF alpha mutant, they usually actually do not retain a contrast, and they are actually not high risk for malignancy either. So with this in mind, it's basically we are less confident of slam dunking FNH in hepatobiliary phase. We always have to give a differential and basically judge case by case based on the overall presentation, age, gender, and then how it's doing over time. But just bear that in mind that hepatobiliary is not specific to FNH. Although there are some situations that they can be extremely helpful. For example, in cancer patients, especially colon cancer patients, which sometimes, especially in young colon cancer patients metastatic to liver, surgeons really want to know each and every lesion, maybe for segmental resection or for local therapies like microwave ablation. They're very important for them to know each and every lesion. So the colon cancer metastases are basically mostly dark on hepatobiliary phase. So when you use the hepatobiliary agent for metastasis detection, it shows you very beautifully all the lesions. And then also during the course of chemotherapy, there are some lesions like FNH-like nodules that happen because of vascular changes associated with some chemotherapy agents, particularly oxaliplatins, that the hepatobiliary phase will show them very beautifully that they retain contrast because they're technically similar lesions as FNH. And then with that, we can differentiate metastases from FNH-like nodules. So that is one important usage of the hepatobiliary contrast. Also bear that in mind that in patients with a predisposing risk for HCC, again, we cannot use hepatobiliary retention as something that, oh, this is FNH, don't worry about it. Unfortunately, especially well-differentiated hepatocellular carcinoma in 8.8 to 14% of time can retain contrast with overexpression of OATP. Although in the LIRAS criteria, when you have a lesion that retains contrast and all of a sudden loses it, it is a negative factor. This is something that raised suspicion, and we don't like the lesions to lose their ability to retain, meaning that they are maybe going under basically low differentiation. But when they retain contrast, it doesn't mean that they're necessarily benign because well-differentiated HCC can retain that. Sorry, I just wanted to basically go over quickly about EOVIST and their usage. Going back to our differentials, hepatic adenomas, also they happen about 3 to 4% per 100,000 cases, also common in young females, third to fourth decade, and they are very, very uncommon in males. There are very specific risk factors in males that can cause hepatic adenoma, particularly usage of steroids, and also glycogen storage disease can increase risk of adenoma in males. Their clinical presentation are usually 50% of the time is incidental, 40% it can have some symptoms like right upper quadrant pain. When there is more than 10 adenomas throughout the liver, we sometimes call them adenomatosis. The risk factors, as you all, I'm sure, are aware, are OCPs, steroids, as I mentioned, glycogen storage disease, hepatic steatosis, and metabolic syndrome increases the risk. The complication of adenomas, they're not as indolent as the lesions we talked about already, like hemangiomas and FNH. About up to 20% of them can go under hemorrhage, especially if they're large, and the size cutoff that is important to remember is 5 centimeter. Above 5 centimeter, the risk of bleeding increases. Some variants of it has risk of malignant transformation. As I already mentioned, the beta-catenin is the highest one. And especially during pregnancy, the risk of growth, rupture, and hemorrhage increases. Sometimes when we detect them before pregnancy, they decide either to do, more aggressive treatment for that. And then imaging, again, can be diagnostic, as I already went over the dilemma between FNH and adenoma. They can sometimes be challenging, but sometimes biopsy or follow-up can be helpful. This table goes over different flavors of adenoma, and this is a busy table. Just in summary, know that there are four big categories: inflammatory, HNF1 alpha mutated, beta-catenin, and mixed inflammatory and beta-catenin. These are some subtypes. And then Sonic Hedgehog and unclassified are basically the large groups. The inflammatory adenomas mostly happen in females. They are usually associated with obesity, metabolic syndrome, or alcohol use. Their presentation on imaging has this classic atoll signs with basically a rim of hyperintensity on T2 and also a rim of hyperenhancement basically on all the sequences, including hepatobiliary. They can have this rim of uptake or basically rim of retention. But this atoll sign is to be honest, not always present, is actually very rarely seen. Mostly something that make us think of inflammatory is the T2 hyperintense signal. As I already told you, like when you look at an FNH, is usually ISO, but some adenomas could be hyper. Those mostly are the inflammatory subtype. These other one, HNF1 mutated, is I like them the most because they are very easy to diagnose and they are very basically they don't have a high risk of malignancy. It's just 5%, and low hemorrhagic risk as well when they're small. They're mostly associated with OCPs. They happen more often in women, 90 to 10 ratio, and they have this classic homogeneous microscopic fat in them. Basically, if you use in phase and out of phase, they have this diffuse loss of signal because of intralesional fat. And this is among the very few types of adenomas that you can slam dunk diagnose it by imaging. Again, follow-up is helpful, but this is like super highly suggestive of an FNH1 alpha adenoma. But the beta-catenin and the other subtypes are unfortunately not very specific by imaging. They can have any sort of appearance. They can be arterially hyperenhancing, they can be heterogeneous, they can have retention of hepatobiliary agents, and they're usually more heterogeneous than the HNF1 alpha subtypes. They can even have intralesional fat. So they're really non-diagnostic they can be not slam dunk by imaging. This is an example of an inflammatory adenoma. Again, you see this compared to the background liver. It is a little bit bright. This one also has this T2 bright central scar. Again, to say that the central scar is not specific to FNH. This has this faint rim of hyperintensity on arterial phase, quote unquote, the atoll sign. And also this is the hepatobiliary phase that shows this rim of retention of contrast, again, atoll sign on hepatobiliary phase, classic of inflammatory adenoma, which is not always seen, but when you see it is very helpful. This is an example of an HNF1 alpha inactivated adenoma. Again, you can see that on the F and G images, the lesion has homogeneous loss of signal on opposed phase, meaning that there is intralesional like fat, microscopic fat. And then on the hepatobiliary phase, as you see on image E, there is absolutely no retention of contrast. And on the central image, it's arterially hyperenhancing, and it can wash out or it can be isointense on delayed phases, but this is diagnostic and by imaging. And then going back to our case, now if you look back, you see these T2 hyperintense lesions with continuous nodular enhancement with peripheral filling, although the lesion is not completely filled in on the most delayed images. So hemangiomas are not a good differential for them, although they can be hemangiomas, but we cannot slam dunk it because it's continuous again. And also some of the lesions have this central necrosis, if you will, and they do not completely fill in, so we cannot diagnose them as hemangioma. They are too bright for FNH. FNHS are usually ISO to the background liver. There, if you will, there are also too bright for adenomas as well. But adenomas classically have this hyperintensity. It's not a rim-like that gradually fill in. So they're not a good look for adenomas either. So these are suspicious lesions, and we should recommend either short-term follow-up or biopsy. And in this case, this patient underwent biopsy, and this came back as metastatic chordoma. Just a very basically small note about chordoma. You can see this sagittal T2 based MRI. This is a tumor arising from the sacrum in the midline, which is basically extremely T2 hyperintense kind of fluid signal. It appears as a lytic or lucent lesion on CT, and it has, this is not a perfect example, but has a brisk enhancement. And it's, I put the T1 pre and post to show that there's intralesional enhancement. So they can very much mimic hemangioma on an MR, but if we look carefully on those important notes, we wouldn't miss them. A quick note about chordomas: there are uncommon malignant tumor from the notochord remnants. They account for about 4% of bone tumors. The most common site of them is the sacrococcygeal bone, usually in 50 to 60 years of age, and it has a male to female ratio of 2:1. So it happens mostly in middle-aged men. The second most place is spheno-occipital bone, and sometimes they happen in vertebral bodies. They're slow growing. They're usually not metastasizing tumor. Of course, our example was had metastasis, but they're usually locally aggressive. They take them out, they recur at the site of surgery. Again, they have to take them out, they recur at the site of surgery. They rarely can be malignant and metastasize, similar to our example. Okay. Does anyone have any questions or anything unclear before I go to next case? All right. I take that as a no. And next case is a 65-year-old male that came with chronic fatigue and recent unexplained weight loss. And then this is a CT of him basically done for evaluation of his symptoms. I just am showing the positive portions of the CT. You see there is this rim of soft tissue encasing the aorta. There is this kind of infiltrative soft tissue in the pelvis that is basically hugging the bladder. It's abutting the prostate kind of anteriorly and laterally. And also there is this infiltrative soft tissue encasing the renal pelvis with some fat stranding around it. And these were the positive findings for him. So think about the possible diagnosis that you think that this patient can have: urothelial cancer, lymphoma, IgG4 related disease, metastasis, or all of them are possibilities. One take-home message from this presentation: if ever you see all of the above, it's always the answer, and probably the answer of our case as well. I'm going to go through all those differentials by imaging real quick. So this is an example of a urothelial cancer. You can see that there is this infiltrative soft tissue encasing the renal pelvis and proximal ureter. They can have this kind of hazy, fat, strandy look as well. There is an important, very important point about the urothelial cancers, that there is a field effect, meaning that whatever carcinogen that was secreted into the renal collecting system goes throughout the ureters and into the bladder. So all that urothelium are exposed to what has caused the cancer. That's why when you see one lesion in the urothelial system, you have to look for others. They are usually multifocal. They either happen at the same time, meaning synchronous, or you take it out, the patient is no evidence of disease, you put them on surveillance, later on you find a lesion. meaning metochronous. So either at the same time or later on, remember that the urothelial cancer is a multifocal disease. Lymphoma. The lymphoma, of course, has many presentations in the abdomen, pelvis. One of the classic teaching is that it can happen as an infiltrative soft tissue in the retroperitoneum, with the classic teaching as it elevates the aorta. Basically, it causes about anterior displacing the aorta. And in the kidneys, they can have a variety of presentations. They can just have renal enlargement, fat stranding near the kidneys. They can have multiple masses in the kidneys, or they can present as an infiltrative soft tissue encasing the collecting system. Any sort of presentation can be lymphoma, basically. There is no exception. This is an example of a lymphoma in the kidney that presented with two hypoenhancing masses in the upper and lower pole. Other basically presentations of lymphoma in the abdomen, of course, can be circumferential thickening of the bowel with this classic aneurysmal dilation or dilatation of the bowel, because they affect the basically. But the classic teaching they usually do not cause obstruction, although we have seen cases of lymphoma causing obstruction, so it's not a ruling out factor, but classically they're not associated with obstruction. And there's another entity, peritoneal lymphomatosis, exact similar presentation as peritoneal carcinomatosis. You can see the scattered nodules throughout the peritoneum, masses throughout the peritoneum, even ascites, and that can be a presentation of lymphoma. Here I'm showing you a case of lymphoma of the prostate. Again, that infiltrative soft tissue can present in the pelvis and then can hog the prostate. If you do not know the history of this patient, this specific patient had a history of diffuse large B-cell lymphoma previously in the abdomen. And then if you do not know the patient's history, by this look, an enhancing mass in the posterior peripheral zone, evil gray on T2, restricting diffusion, your first and second and third differential is prostate cancer. But know that lymphoma can have similar appearance. This was an example of a biopsy-proven lymphoma of the prostate. And one very important differential not to please forget is metastasis. Metastasis can appear as this infiltrative retroperitoneal soft tissue encasing the vessels, encasing the urethra. This is an example in a patient that on the coronal image, you see there is some thickening in the gastroesophageal region. It's very sneaky, very easy to go by, but there is a lymph node near it that may basically raise suspicion that, okay, maybe there's something going on. But you can see even this sneaky small cancer is presented with this super infiltrative soft tissue, retroperitoneal soft tissue encasing the vessels, which was biopsy proven metastatic adenocarcinoma of the gastroesophageal junction. So never forget this important differential when you see infiltrative soft tissue. And then we're going to have a little bit of a talk about IgG4 related disease, which is also an important differential in this setting. So IgG4 related disease is a systemic immune mediated disease with multiple manifestations in the abdomen. The most common site of involvement in the abdomen is pancreas, and then the biliary tract and retroperitoneum, although any other organ in the abdomen can technically be involved, and we are going to go over examples. But remember that these are the three most common sites of involvement. When they are basically happening in only one organ, the diagnosis is challenging. It's among a list of differentials. But when it involves multiple organs with that classic look, we can be more confident in our differential about IgG4 related disease. And also I wanted to point out that although the name is IgG4 related disease, and we expect that, okay, in all the cases we need to have elevated IgG, that's not the case. in majority of them are, but if the IgG4 level is normal, it does not rule out IgG4 disease, and it needs biopsy for definitive diagnosis. And in the cases that it's challenging to biopsy, or for every reason the diagnosis is equivocal, then they sometimes put the patients on a trial of steroids. And the great response to steroids is also a confirmation of the differential, basically that helps with confidence in your diagnosis. This is a busy table showing all the various organs in the abdomen and pelvis that can be involved with IgG4 disease. I'm going to go over a few of them by imaging, but just remember the pancreas is the most common. It has this classic sausage shaped with a peripheral rim of enhancement. I'll go over that in real quick. It can involve the biliary system, mostly appearing as a long segment stricture of a distal CBD. It can happen in retroperitoneum. As you are all aware, basically we call it idiopathic retroperitoneal fibrosis if we don't have this classic IgG4 disease, but most of the retroperitoneal fibrosis cases are actually IgG4 related. They can involve the vessels, they can encase them, they can cause pseudoaneurysm, they can cause dissection. Always when you're thinking about IgG4 disease, please look at the coronary vessels because they can be involved, and of course they're super dangerous, and the patient needs to be on treatment sooner than later. So remember that they can involve coronary arteries. So take a look at that base of the chest in your CT. They can involve lymph nodes. They can present with lymphadenopathy. They can involve the kidneys. I'll show you examples. They have this classic round or wedge-shaped hypo-enhancing lesions that can sometimes be mistaken for even pyelonephritis or renal infarct because they have this classic wedge-shaped sometimes. They can involve the prostate. I'll show you example as well. The most important differential would be prostate cancer, but if there is a multi-site of involvement, you should know that they can involve prostate as well. And also peritoneum, mimicking peritoneal carcinomatosis, similar to peritoneal lymphomatosis. They can happen as nodularity or masses. And sometimes the masses is a central mass with some calcification tethering the bowel, which we call it sclerosing mesenteritis. Also, a part of a sclerosing mesenteritis cases is IgG4 disease. So this is a classic look in the pancreas. This is an MRI T1 pre, MRI T1 arterial phase, T2, and an MRI T1 post-contrast delayed. You see that the pancreas has this diffuse loss of normal low T1 signal with this classic sausage shaped and loss of this normal basically look around it. It has this rim of T2 dark around it, surrounding it, that has this late enhancement. You can again appreciate that there is this T2 dark rim with delayed enhancement. And then one other classic look of it is that if you look at the pancreatic duct, I don't know how good you can see it, there are some areas that the pancreatic duct is kind of lost, we don't see it, and then some areas that it comes back again. And upstream to those areas which you lose the duct, there is no ductal dilatation. So that's also a classic look, that you lose the duct and you see the duct, you lose the duct, and there's no really ductal dilatation. This is an example of a focal pancreatic involvement by IgG4 disease on a CT. Again, there's an area of hypoenhancement usually with delayed enhancement. So basically early arterial hypo and later on delayed. You lose the duct in that area of involvement with classically usually no upstream ductal dilatation. Of course, when it's only focally involving the pancreas, the most important differential is pancreatic cancer. When there is no main ductal dilatation, that's reassuring. Then the patient goes on steroids and it goes away, that's all reassuring. But you should always think of pancreatic cancer as a differential. Classic teaching is that when they put them on steroid and the patients basically get treated, This is a classic post-treatment look for IgG4 disease. The whole gland that was previously sausage-shaped and diffusely kind of enlarged now becomes atrophic. Sometimes we have small strictures in the duct, but usually not. It's just an atrophic look of the gland. So if you see a pancreas like this, always think that this patient might have previously undergone an IgG4 disease treatment. In the biliary system, the classic presentation is a long segment stricture of the CBD, of the distal CBD. You can see in this example, the distal CBD or the intrapancreatic portion of the CBD has this circumferential T2 hypointense thickening with kind of diffuse enhanced on the post-contrast on the axial. And then on the intrahepatic bile ducts, it can have a similar appearance to PSC, basically this multifocal narrowing and dilation. But this classic look of distal CBD involvement should make you think of IgG4 disease, especially in the right patient population and with synchronous involvement of the pancreas. It should raise the possibility of IgG4. This is an imaging example of a retroperitoneal involvement, basically RP fibrosis associated with IgG4 disease. The classic teaching is that usually involves the anterior lateral of the aorta and the posterior border is spared, in contrast to the lymphoma, which encases the whole aorta and moves up the aorta. So when we say, oh, the lesion is like raising the aorta, it's most likely lymphoma, but if it's not, it's IgG4 disease. Again, it's not like written on stone. All of them can do everything, but when you see the lesion that is sparing the posterior, it's more favored IgG4 rather than lymphoma. And then the vascular involvement of the IgG4 disease, which, as I already mentioned, that can involve aorta, iliac, most importantly, coronary arteries, even carotids. They can be associated with aneurysm, stenosis, and dissection. This is a case of IgG4 disease that we saw the aorta on the previous slide. This is involvement of the common iliac on the right and is associated with this large aneurysm of the iliac related to IgG4 disease. The renal involvement of IgG4 have different variants on imaging. They cause basically what is called as tubulointerstitial nephritis. One of the classic looks, as you see on the image on the left, you see this subcortical, small, hypodense nodules bilaterally. That's actually one common presentation of them. This tiny nodules subcortical bilaterally. Another presentation is wedge-shaped hypoenhancing lesions. If you do not know the patient's history, this is a good look for pyelonephritis or renal infarct. But in the setting of IgG4 in other organs, you should note that this can be a presentation of IgG4 disease. This is a coronal and sagittal view of the same patient showing this wedge-shaped, multiple wedge-shaped areas in both kidneys. This is an example of IgG4 disease involving the prostate, usually similar to the way that lymphoma can involve the prostate. This is an outside-in disease, meaning in contrast to prostate cancer, which usually starts within the parenchyma and goes out. This usually starts in the surrounding prostate tissue and then involves the prostate and bladder from the periphery. But there are cases that the IgG4 disease happen within the parenchyma too, but the classic look is outside in disease with diffuse involvement of the peripheral zone with or without involvement of the transition zone. And when it involves the whole gland, you lose the normal zonal interface of the prostate. This is an example of IgG4 disease in a prostate. As I mentioned, they can involve the lymph nodes. They can present with lymphadenopathy. Again, if they just happen as isolated lymphadenopathy, this is a laundry list of differentials, but in the multi-organ involvement, you should know that lymphadenopathy can also be a part of this. You see this patient on the kidney, on the left kidney, you see that classic wedge-shaped areas. So this patient very likely has multi-organ involvement. And that was it. And just going back to our case, this was a case of IgG4 disease. I showed the examples in my slides. This was an aortic involvement, this was prostate and bladder involvement, and this was the urothelial involvement of the IgG4 disease in this 65-year-old male. And with that, I'm done. If there's any questions, anything, I'm happy to answer.
Thank you so much. That was really some really interesting cases. Thank you so much for showing them.
Absolutely.
Especially, I think that metastasis was phenomenal.
Thank you. Yeah, something very sneaky. We have to be careful.
Absolutely. And really fabulous discussion, I would say, really went into the details of the differential